Thank you very much for your invitation. I really enjoyed the former speakers and I've learned a lot. I will give you a little bit different perspective with this presentation. I will try to report shortly the status of liver transplantation, and I will report then some data mainly of salvage liver transplantation in patient who has had previous laparoscopic liver resection. So as everybody knows, HCC is most frequently associated to liver disease, and that's occurring in 90% of cases. And we have evidence that liver transplantation represents an effective therapy with excellent result for selected patients with hepatocellular carcinoma. What is still under debate is the best way to select HCC recipients for liver transplantation and how to prioritize them while they are on the waiting list. This, has been reported recently both in the United States and Europe. And if you look at the data of the European Liver Transplant Registry, you see that still liver cirrhosis is the main indication for liver transplant, but the proportion of cases performed for hepatocellular carcinoma is constantly increasing. And in some area of Europe, such as Southern Europe, hepatocellular carcinoma represents 50% of the indication for liver transplantation. One more interesting thing is that if you look at the most important gain in the overall survival after liver transplantation, you see that occurs for HCC patients, and this reflects an improvement in the selection of those recipients. Oh, thank you. So I was just giving some backgrounds on the actual state of liver transplantation in Europe. And as I said, you see that especially in the southern part of Europe, hepatocellular carcinoma represent the 50% of the indication to liver transplantation. And what is more important, if you look at the most important gain in the overall survival among all the indications for liver transplantation, you see that the dose is mostly shown in hepatocellular carcinoma patient, reflecting and improving in patient selection. Since Mazzaferro original paper in 1996, we all learned that hepatocellular carcinoma is an excellent indication for liver transplantation at the early stage. And there is, since then, a lot of pressure in trying to expand criteria for liver transplantation. But this has to be, coupled with the organ donor shortage, which is a constant problem, and especially in the field of HCC with the tumor recurrence. Looking at tumor recurrence, we know that many factors are, responsible for recurrence of HCC after liver transplantation. Some of those factors are related to the donor, some to the biology of the tumor. And what is really impressive is the numbers of papers and studies that are trying to push the limits towards enlarged criteria, for expanded criteria for transplantation in hepatocellular carcinoma. Some of those papers rely on morphometric criteria, so trying to enlarge the number of nodules and the size of nodules that can be transplanted, while on the other hand, some other studies are focusing on the biology of the tumor. But in Italy, since few years, we adopted the so-called blended approach, looking at the urgency, utility, and transplant benefit in the light of based evidence medicine. That is important because we are trying to transplant hepatocellular carcinoma only if there are no other options. So trying to give a priority to patient without the liver, without the HCC. And that is possible even because the HCC patient can be treated with liver resection and minimal invasive liver resection. So considering all the surgical options to transplant patient with hepatocellular carcinoma, there are several surgical techniques such as live donor, split liver transplantation, donor after cardiac death that can give us the opportunity to enlarge the pool of donors that are particularly good match for hepatocellular carcinoma patients. And the outcome for patients transplanted with different surgical techniques are good, so they can be safely used in the context of the hepatocellular carcinoma. If you look, for example, at the data of patients with HCC transplanted with extended right graft resulting from in situ split, we have an Italian multicentric studies which show that 25 of those recipients were HCC patients. And obviously, looking at the few Western centers with high volume live donor transplantation, you see that looking, for example, at the Pittsburgh series, 90% of the recipients were HCC recipient. The donor shortage is particularly, tough in the south of the country where my center is located. You see, in Italy, we have center with the donor per million people ranging between 30 and 40. And in the south, our center with less than 10 donor per million people. So what we are doing is accepting liver that are rejected by other centers. So if you look at the number of transplant of liver overflow, so liver that were originally refused, we were in the last 3 years the center who did the most of those cases. And this is going to impact our indication to liver transplantation for HCC. Going to the simple surgical thinking, there are two crucial points when you put the patient in the list for HCC. Again, the selection criteria and the way to give priority to those patients while in the list. Then we have primary liver transplantation, which is the best treatment for patients with the decompensated liver function and hepatocellular carcinoma, and salvage liver transplantation, who is considered after a failure of a treatment, a primary treatment, which could be liver resection or local regional therapy in case of recurrence of hepatocellular carcinoma. And if you look at the data, maybe not all patients who receive the primary liver resection can be doable, can be transplantable. But if you look again at the overall survival, obviously, salvage liver transplantation has a worse survival, 3-year, 5-year overall survival compared to primary liver transplantation. But if you look at the repeat liver resection for hepatocellular carcinoma recurrence, you have a lower disease-free survival compared to salvage liver transplantation. And if you compare salvage liver transplantation to repeated liver resection, you see that again, salvage liver transplantation may have an higher intra and post-operative morbidity, but if you look at the 5 years cumulative incidence of HCC, the recurrence is lower than repeated liver resection. And what is most important is what is happening since at least 10, 20 years with the success of the minimally invasive liver resection. So there is a great interest, especially in the field of salvage liver transplantation. We, together with other 5 Italian centers, so a total of 6 Italian centers, did this retrospective intention to treat analysis looking at 210 patients who had a previous liver resection, 167 open liver resection, and 44 laparoscopic liver resection, who eventually were waitlisted for liver transplantation and all had transplantation. And what is extremely interesting is that minimally invasive surgery was a protective factor. You see that considering the failure of salvage liver transplantation and the death after salvage liver transplantation, patients who had previous laparoscopic liver resection did much better compared to patients who had previous open liver resection. So minimally invasive surgery resulted in mitigate the higher operative mortality and morbidity, which was connotating historically the salvage liver transplantation. And what is interesting is that those results were confirmed by a propensity score matching in a balanced population for type of resections and tumor size, although we must admit that the most majority of laparoscopic liver resections were wedge or single segment segmentectomy. And you know, in our center, out of 1,400 liver transplantation, we have done about 36–37% of transplant for hepatocellular carcinoma, and about 40% of our 1,400 liver resection were done for hepatocellular carcinoma. In the field of liver resection, we are now, you know, doing more laparoscopic liver resection, which now are about 40% of all liver resection we perform. And most majority of those patients as patients between the child A and B referred for liver transplantation. So the great majority of those resections are wedge resection of 1 or 2 nodules. One thing that has been done laparoscopically with great impact on liver transplantation is also the laparoscopic thermal ablation, which has been particularly useful in lesions located in the upper and the posterior segments of the liver, and that were not, you know, indicated as possible to do as percutaneously. So putting together all our patients who had laparoscopic thermal ablation or laparoscopic liver resection, we did some consideration in those who received then salvage liver transplantation for a recurrence of the tumor. This is a series of 40 patients who had in 30 cases laparoscopic liver resection and in 10 cases laparoscopic thermal ablation. And you see then that the most majority of patients eventually received the salvage liver transplantation within 2 years since the first laparoscopic approach. And if you look at the overall survival, comparing this cohort of 40 patients operated with liver transplantation after laparoscopic liver resection or thermal ablation, and you compare to a group of other 40 patients who had open surgery of the supramesocolic space, you see that there is a big difference in terms of overall survival, in terms of length of stay, in terms of blood product transfusion during transplantation. So this is a typical case of patient who goes through this possibility to have a first treatment with the laparoscopic approach and then a salvage liver transplantation. 55 years old with HCV related cirrhosis who has had a DIA treatment, and then you know, he was diagnosed with an HCC on the posterior segment 7, and he had a liver resection 2 years ago, laparoscopic liver resection, then he recurred 1 year after, and then was transplanted 2 years ago. So you have in the picture the laparoscopic liver resection, and I hope that I can show you that basically at the time of transplant, no adhesion were present or just small adhesion. So what really impact in these cases is that even if you have been there once or 2 times for one laparoscopic ablation or one laparoscopic liver resection, at the time of transplant, you basically don't find adhesions, or you find few adhesions, and that is completely another scenario compared to patient who has had the previous open surgery. So liver transplantation is the perfect scenario to really give value to the laparoscopic treatment of HCC. And again, I'd like to conclude reporting a few statements. Recipients in liver transplantation list that has had bridged or downstaged their tumor with the laparoscopic approach, they have a great advantage in this technique, mainly due to the prevention of the postoperative abdominal adhesions. And laparoscopic approach seems protective over open surgery. If you look at the data, if you look at the risk of dropout of those patients, at the list of post-transplant death, and obviously also in the oncologic setting at the risk of tumor recurrence. So thanks again for your patience, and I like to show our team which just won the European Cup. Thank you.
Thank you very much, Dr. Gruttadauria. Thank you very much. And it is a very excellent lecture that by laparoscopy, you can do better survival after salvage liver transplantation. I think, as you already mentioned, you can have a less adhesion and better liver function, I think, yeah, right?
Absolutely. You have less adhesion, and you know, the operation is completely different, and so patient can be treated once, 2 or 3 times laparoscopically while they are on the list. So you can spare livers for patient who has not cancer, but when the time comes for them to be transplanted, transplantation is not that difficult as it was used to be after open liver resection.
Yeah, so I think that Professor Moris's lecture is a little difficult, but same result. That the repeat resection, previous laparoscopy repeat resection, laparoscopy repeat resection is better in survival, yeah, compared to open surgery. Thank you very much.